Most people who notice their vision getting worse do one thing. They book an appointment, sit in a chair, read some letters off a chart, and walk out with a new prescription. That's it. That's the entire response to a progressive physiological problem, a stronger lens to compensate for a weaker eye. Nobody stops to ask whether the eye itself could be retrained. Nobody mentions that your eye is surrounded by muscles, real, trainable, atrophy-prone muscles, and that those muscles in most adults are operating at a fraction of their capacity. Nobody tells you that because a new pair of glasses generates revenue and a 3-minute daily exercise routine does not. I'm going to tell you anyway. Subscribe to Dr. Waterling right now and hit the like button. We are working toward 1,000 subscribers and every single one matters. Here's what I want you to understand before we go any further. The system you trust with your health is not financially incentivized to make you well. It is incentivized to keep you returning. What I'm about to share doesn't require a copay. Let's begin with anatomy. Not the dead, memorized for an exam kind, but the kind that makes the rest of this make complete sense. Each of your eyes is controlled by 6 extraocular muscles. That word simply means muscles on the outside of the eyeball. These are the muscles that physically move the globe, that turn your eye left, right, up, down, and in rotation. Let's go through each one because understanding what they do is what makes the exercises meaningful rather than arbitrary. The medial rectus muscle pulls your eye inward toward your nose. The lateral rectus pulls it outward away from your nose. Together, these two handle all horizontal movement. The superior rectus pulls the eye upward, and because of the geometry of how it attaches, also rotates it slightly inward. The inferior rectus pulls the eye downward with a complementary rotational component. And then the two oblique muscles, the superior oblique and inferior oblique, are primarily responsible for torsional movement, meaning rotational adjustments that keep your visual field stable when you tilt your head. All 6 of these muscles fire in coordinated sequences every time you shift your gaze. Not one of them dominates. Not one of them can be removed from the system without degrading the whole. Now here's what most people, including a surprising number of clinicians, do not fully appreciate. These 6 extraocular muscles are not the only muscles governing your visual function. Inside the eye itself, you have the ciliary muscle. This is the muscle that physically reshapes your lens. The lens is the transparent, flexible structure sitting just behind your iris, the colored part of your eye. When the ciliary muscle contracts, it releases tension on the fibers holding the lens, and the lens rounds up, increasing its optical power for near focus. When the ciliary muscle relaxes, those fibers pull the lens flatter, reducing its power for distance focus. That constant dynamic adjustment, the eye shifting its focal length from near to far and back again, is called accommodation. You also have the sphincter pupillae muscle, which constricts the pupil in response to bright light, and the dilator pupillae, which opens it in dim conditions. Add it all up, a minimum of 8 muscles per eye, 16 for both eyes combined. 16 muscles that respond to training, that deteriorate from disuse, and that most people never deliberately exercise a single day in their lives. I want you to really sit with that number for a moment. 16. If you told someone you were going to get into shape, but you only intended to exercise 2 of the 16 major muscle groups in your body, they would look at you like you had lost your mind. But that is effectively what happens with the eyes. Modern life demands near constant, near distance focus. Screens, phones, books, dashboards, and almost never demands the full range of extraocular movement. The muscles responsible for peripheral gaze, for coordinated rotational tracking, for rapid long distance focus shifts, they spend most of their working lives nearly idle. Now, before I give you the 3 exercises, I want to address something I hear constantly in advertising, and it irritates me every single time. The claim is always some version of, do this one move and your vision improves dramatically. I want you to understand why that claim is physiologically absurd. Imagine being told that if you train only your index finger, you will become a concert pianist. A piano demands 10 fingers working in precision coordination. Your visual system demands 16 muscles doing the same. One exercise targeting one movement plane cannot produce comprehensive visual improvement any more than training one finger can produce musical mastery. What produces results is a systematic, complete, multiplanar approach, one that addresses the extraocular muscles, the internal focusing muscle, and the supporting tissue around the eye. That is what I am going to give you. No miracles, just physiology applied correctly. The first exercise is one I call the wipers. I'm going to tell you exactly where it came from because the origin matters for understanding why it works. Early in my career, I spent time at significant altitude, somewhere in the range of 13 to 16,000 feet above sea level. I was young, I was overconfident, and I did not wear UV protective sunglasses. That was a real clinical mistake, and I paid for it. Here is what most people do not know. Ultraviolet radiation intensity does not stay constant as you gain elevation. It increases substantially. Above roughly 8 to 10,000 feet, UV exposure is dramatically higher than at sea level. The atmosphere is thinner, there is less filtration, and the radiation reaching your eyes is far more intense. At elevations above about 8,000 feet, UV exposure is sufficient to cause photochemical damage to the retina, the thin neurosensory layer at the back of the eye that actually converts light into electrical signals your brain reads as vision. I came down from that trip and noticed a real, measurable deterioration in my vision. Not catastrophic, but undeniable. And rather than simply accepting a new prescription, I started experimenting. The wipers exercise was one of the interventions that produced the most rapid, noticeable improvement. Here is exactly how you perform it. Without moving your head, look as far as possible to the right. Maximum lateral gaze. Take your eye to the absolute edge of its range. Now, maintaining that position at the extreme edge of your visual field, begin sweeping your gaze slowly in a wide horizontal arc from the far right all the way to the far left. Then back again. The movement should be slow and deliberate, not a quick flick, but a controlled, smooth sweep along the outer boundary of your peripheral vision. The amplitude is maximum both directions. You should feel a distinct pulling or stretching sensation in the muscles on the side opposite to the direction you're moving toward. I called this exercise the wipers because of a precise functional parallel. The way windshield wipers clear rain and smearing from the glass and restore a clean, sharp view of the road ahead. That is exactly what this exercise does for the visual field. It clears the blur, it restores acuity, and most people feel the effect within 1 or 2 repetitions. When patients perform this exercise for the first time, the most common reaction is discomfort, sometimes actual pain when the eye reaches its far lateral position. I want to explain this clearly because people often assume it signals injury, and it does not. What it signals is a lifestyle diagnosis. Think about how your eyes actually move during a typical day. You look at your phone, you look at a computer screen, you look at a television, occasionally you glance at someone across the room. In all of these activities, your extraocular muscles are operating in a very narrow range. Research suggests that for most modern adults, the functional range used in daily activity represents roughly 10 to 15% of the full available arc of motion. Day after day, year after year, the muscles operating outside that narrow range receive almost no demand. Like any skeletal muscle subjected to chronic underuse, they shorten, stiffen, and lose their elasticity. Connective tissue tightens around them. When you then drive your eye to the far edge of its range, the muscle on the opposite side, the one that has to lengthen to allow that movement, pulls against that stiffness, and you feel it. Now here is why this is not just about comfort, and why the wipers exercise has clinical significance beyond simple stretching. Chronically tight, rigid extraocular muscles do not simply cause discomfort. They exert mechanical pressure on the eyeball itself. The eye is not a completely rigid structure. It has walls, it has internal fluid dynamics, and it responds to external pressure. When the muscles surrounding it are in a state of chronic contraction and tension, they compress the globe. That compression affects the microvasculature, the small blood vessels supplying the retina. The retina is neural tissue. It is, in a very real sense, an extension of your brain located inside your eye. Neural tissue is among the most metabolically demanding tissue in the human body, and it is exquisitely sensitive to reductions in blood supply. When retinal perfusion is compromised, even modestly, visual acuity declines. So when you perform the wipers exercise with maximum amplitude and feel that stretch, You are not just loosening tight muscles for comfort. You are actively reducing mechanical compression on the eyeball, restoring vascular flow to the retina, and improving the nutritional and oxygen supply to the tissue responsible for your vision. If you commit to doing this exercise daily, here is what the timeline typically looks like based on what I have observed in patients. In the first week, the discomfort at the extremes of gaze decreases noticeably. By the end of 2 to 3 weeks, it is largely or completely gone. The disappearance of that discomfort is a reliable clinical indicator. It tells you that the extraocular muscles have regained a functional, healthy resting tone. They are no longer operating in a state of chronic shortening. And once that baseline is established, maintaining it requires only a few minutes of daily practice. The second exercise is vibrational massage of the eyeball. I want to explain the physiological rationale for this before I give you the technique, because the rationale is what distinguishes this from something arbitrary. In manual therapy and professional massage, there are 4 fundamental intervention types: effleurage, which is smooth gliding surface contact; friction, which is a deeper, more localized rubbing pressure; kneading, which is compression and rhythmic release; and vibration. Of these 4, vibration is uniquely capable of transmitting mechanical energy deep into tissue. It travels as a propagating wave, not just affecting the surface layer, but moving through the full thickness of whatever structure it contacts, including layers that cannot be directly reached by surface pressure. This is well established in manual therapy literature and is the reason vibration techniques are used specifically when the target tissue is deep. Now apply that principle to the eye. The eyeball is roughly the size of a ping pong ball. Inside it, you have the vitreous humor, a gel-like substance that fills most of the interior volume and maintains the shape of the eye. You have the 3 concentric layers of the eye wall: the sclera on the outside, which is the tough white coat; the choroid in the middle, which is densely vascular, meaning it is full of blood vessels that supply the eye; and the retina on the inside. You have the optic nerve entering from the back. All of these structures are surrounded by the extraocular muscles and orbital fat, wrapped in a fibrous capsule called Tenon's fascia. If you want to produce a beneficial effect on all of these structures simultaneously, improving circulation through the choroid, relieving tension in the orbital connective tissue, normalizing fluid dynamics within the vitreous, surface pressure is not the right tool. Direct, forceful pressure on the eye is in fact contraindicated. It can transiently elevate intraocular pressure, the pressure inside the eye, and in susceptible individuals, that can be dangerous. Gentle vibration, however, is physiologically appropriate. It stimulates microcirculation, promotes tissue fluid exchange, and gently mobilizes the surrounding connective tissue without generating harmful pressure spikes. Here is the precise technique. Place one finger at the inner corner of your eye, the medial canthus, the point where the upper and lower eyelids meet near your nose. There is solid bony support there from the nasal bone immediately underneath. Place a second finger at the outer corner of the eye, the lateral canthus, where you have the lateral orbital rim, also solid bone, as your support. This is critical. Both fingers should rest primarily on the bony orbital margin, not on soft tissue. This prevents you from inadvertently applying lateral pressure on the globe itself. Now, with the inner surface of your fingertips, the soft, sensitive pad just below the nail, make the lightest possible contact with your closed eyelid. Not a press, a touch. The weight of the fingers barely landing. From that position, initiate a fine, rapid vibration. Small amplitude, fast frequency. Continue for 20 to 40 seconds without increasing pressure. Then slowly lift your fingers away, pause for 5 seconds, and open your eyes. The majority of people immediately perceive an improvement in clarity. Colors may appear slightly more vivid. Detail at distance or near may sharpen. This is not imagination and it is not placebo. It is improved microcirculation in the choroidal vessels, relaxation of the orbital musculature, and normalization of fluid dynamics within the ocular tissues, all occurring in under a minute. Let me share something that has stayed with me from 15 years in practice. Over the course of my career, I have encountered a handful of patients over the age of 70 who wore no corrective lenses whatsoever. Not reading glasses, not distance glasses, nothing. Clear, functional vision in their 8th decade of life. That is genuinely uncommon. Age-related changes to the lens, the retina, the ciliary muscle, these are expected, documented, nearly universal in Western populations. So what distinguished these individuals? When I asked each of them about their habits, without exception, they all reported doing some form of eye exercises daily, consistently, for years, treated as a non-negotiable routine in the same category as dental hygiene, not as a chore they did reluctantly, as a practice they genuinely believed in and had maintained through discipline. There was something else these patients shared, and I found it striking enough to mention every time this topic comes up. They were cognitively sharp, mentally alert, quick in conversation, clear in their recollections. Now, I want to be careful here and not overstate a clinical observation as if it were a controlled study. It is not. But the physiological basis for a connection between visual exercise and cognitive function is real. The visual cortex, the region of the brain that processes visual information, occupies approximately 30% of the total cortical surface area. That is not a minor structure. It is the single largest sensory processing region in the human brain. Regular, complex visual training, movement across the full range of gaze, dynamic focus shifts, coordination demands, generates sustained neural activity in that cortex. Whether that activity contributes to maintained cognitive function or whether people with maintained cognitive function are simply more likely to stick with disciplined health habits is genuinely difficult to untangle. Most likely, both mechanisms operate simultaneously and reinforce each other. But the association between consistent eye training and preserved mental sharpness is something I have observed repeatedly enough that I no longer consider it coincidental. The third exercise targets the ciliary muscle, the internal focusing muscle, directly. This is the exercise most relevant to presbyopia, which is the clinical term for age-related near vision loss. Presbyopia is what happens when, typically somewhere in the early to mid-40s, people begin holding reading material farther and farther from their face to bring it into focus. It is extraordinarily common. It affects virtually everyone in Western populations who lives long enough. And it is almost universally managed by prescription of reading glasses, progressive lenses, or bifocals. The standard explanation given to patients is that the lens hardens with age and loses flexibility, making accommodation impossible. This is partially true. The lens does become less elastic over time. But here's the part that rarely gets mentioned. The ciliary muscle itself in the presbyopic eye retains its contractile ability. Research has demonstrated that even in presbyopic patients, the ciliary muscle continues to contract in response to accommodative effort. It is the lens that fails to respond, not the muscle that fails to fire. This matters because it means the ciliary muscle can still be trained, can still be maintained, and may play a role in slowing the functional decline of accommodation when exercised consistently from an early enough stage. The standard recommendation for ciliary muscle training is the near-far focus shift. Hold your finger close, bring it toward your face until it blurs, then pull it back out to clarity. Repeat. This works. It loads the ciliary muscle in a single plane, straight in front of you along your line of sight. But I have developed a significantly more effective version, and the modification is simple. Here is the enhanced technique. Bring your finger toward your face until the image begins to soften. You are approaching the near point of your accommodation. Hold it at that distance. Now, rather than simply moving it straight toward you and away from you, begin moving it in a slow circle, upward to one side, downward to the opposite side. Keep moving it through that circular arc while maintaining the clearest focus you can manage. The ciliary muscle must now work not only to maintain near focus, but to adapt that focus dynamically as the visual target shifts in space, changing its position relative to both your eye's optical axis and the extraocular muscles holding the eye on target. Then reverse the direction of the circle. Then begin incorporating distance changes during the circular motion, gradually bringing the finger closer through one part of the arc, then drawing it back out through another part. What you are producing is a multiplanar, dynamically varying load on the ciliary muscle, a training stimulus that is categorically more complex and more effective than simple linear movement. The practical challenge with any eye exercise program is not learning the technique, it is maintaining the habit. And the solution I found through years of trying different approaches both personally and with patients is what I call anchor linking, attaching the new habit to an existing, already automatic daily behavior. I do my ciliary muscle exercise in the elevator every single time. I press the button, I use the overhead light as my visual condition, and for the 30 to 40 seconds of the ride, I run through the circular accommodation drill. It requires no extra time allocation, no willpower to begin, no reminder. The elevator ride is the trigger. For you, the anchor might be different. The first 2 minutes of your morning coffee, the 60 seconds while your computer boots up, the moments waiting for a traffic light. It does not matter what the anchor is, as long as it is genuinely daily and genuinely reliable. Because the cumulative benefit of 3 minutes of these exercises done consistently every day for 6 months dwarfs the benefit of a 45-minute session done once a week. Consistency is the entire game, and the alternative, cycling through progressively stronger prescriptions every 18 months, building a permanent dependency on corrective lenses that must be carried, cleaned, replaced, and upgraded continuously, is a far less appealing long-term arrangement. Now, I want to address something that most people pursuing better vision completely overlook, and overlooking it significantly limits their results. Exercise is a biological stimulus. The response to that stimulus, tissue adaptation, improved function, structural recovery, depends entirely on the quality of the raw materials your body has available to carry out that adaptation. Exercising muscles that are being fed by a nutritionally depleted system produces a fraction of the possible result. It is like trying to build a house while the supply truck keeps arriving half empty. Progressive myopia, nearsightedness that keeps worsening, is almost universally accompanied by specific nutritional deficiencies. The single most important and the most commonly deficient in northern latitude populations is vitamin D. Vitamin D deficiency is not a minor inconvenience. Its relationship to retinal health is documented. It plays a direct role in the function of photoreceptors, the specialized cells in your retina that detect light. Its relationship to the risk of developing macular degeneration, age-related macular degeneration, is the leading cause of irreversible central vision loss in adults over 50, is well established in epidemiological research. And its relationship to the rate of myopia progression in children and young adults is increasingly supported by the literature. If you are doing eye exercises but your vitamin D level is at the floor, you are working against yourself. Get your level tested. It is a simple blood draw. If you are deficient, and in many northern climate populations that means the majority of people, correct it. Supplementation is inexpensive, safe within appropriate dosing ranges, and has a meaningful positive impact not only on your eyes, but on immune function, bone density, cardiovascular health, and mood regulation. Your age is directly relevant to how urgent all of this is, and I want to be specific about why. The ciliary muscle begins to show functional decline in accommodation starting in the late 30s. By the mid-40s, most people are noticing it clinically. By 50, the statistical frequency of macular degeneration risk factors rises significantly. After 60, vitamin D deficiency, if uncorrected, compounds retinal aging at an accelerating rate. So the answer to when should I start is always the same: now, and the earlier the better. Which brings me to something I genuinely want to know. How old are you? Write your age in the comments. This is not a rhetorical question. Where you are in that timeline determines which of these 3 exercises is most urgent for you right now, which nutritional deficiencies are most likely active in your body, and which future videos would be most useful for your specific situation. Tell me your age. I read the comments and the data helps me build content that is actually relevant to where you are. Now I want to bring in an angle that does not come from a clinical guideline or a pharmacology textbook, but that I have seen play out in practice enough times to take seriously. Traditional Chinese medicine developed a system of organ correspondences, mappings between internal organs and the body's sensory systems. The ears correspond to the kidneys, the tongue corresponds to the heart, the eyes correspond to the liver. When this was first taught to me, I filed it under interesting historical curiosity and moved on. Then I started noticing something in clinical practice. When the liver is significantly compromised, when hepatic function deteriorates to the point of jaundice, one of the first and most visible signs is yellowing of the sclera. The sclera is the white of the eye. That yellowing is called scleral icterus, and it appears there in the eyes before it is visible elsewhere on the body in many patients. That is not a metaphor from ancient China. That is a standard physical examination finding taught in every medical school in the world. The ancient correspondence between the liver and the eyes, looked at through a modern clinical lens, turns out to be describing a real anatomical and physiological relationship. The practical clinical implication is this: if your vision is declining, it is worth examining what you are doing to your liver, because the liver's functional state has a meaningful impact on the overall metabolic environment in which your eyes are trying to maintain themselves. What damages the liver most predictably and most directly in the average diet? Two categories. First, fried and smoked foods. When food is cooked at high temperatures in fat, frying, a range of toxic compounds are generated. These include polycyclic aromatic hydrocarbons and oxidized lipid products, both of which are hepatotoxic, meaning directly damaging to liver cells. The liver is the organ responsible for neutralizing these compounds. Every time you eat heavily fried food, you are creating a toxic load that the liver must process at the expense of its other functions. Smoking meat generates similar compounds through combustion. The more consistently your diet loads the liver with these substances, the more its functional capacity for everything else, including producing bile, metabolizing hormones, clearing inflammatory mediators, is consume control. Second, processed meats. This is a separate problem from cooking method. Processed meats, the kinds sold pre-packaged, sliced at counters, pressed into casings, contain a combination of nitrites, synthetic colorants, preservatives, and flavor enhancers. These compounds exist in the product for industrial purposes, to extend shelf life, to maintain color, to produce a palatable taste profile that makes the product sell. None of them serve any nutritional function. All of them must be processed by the liver. The less adulterated your food is before it enters your body, the less chemical burden you on the organ that is quietly doing the largest share of your body's detoxification work. There is one more factor I want to name, and I want to name it directly because it almost never appears in the clinical literature, despite being something I have observed repeatedly over 15 years of seeing patients. Chronic anger is a physiological stressor, not merely an emotional state. Sustained irritability, frequent flares of hostility, persistent low-grade frustration, these are not character traits that exist independently of your body's biochemistry. They are associated with chronic activation of the stress response, sustained elevation of cortisol and catecholamines, which are the hormones your adrenal glands produce under stress. Chronic stress hormone elevation drives systemic inflammation, impairs bile flow from the liver, and over time contributes to hepatocellular, meaning liver cell, dysfunction. In the Russian language, there is a word, zhelchny, used to describe a bitter, irritable, choleric person. The word literally comes from the word for bile. That linguistic choice was not accidental. It encodes an observation that practitioners made long before the biochemistry was understood, that chronic anger and a burdened liver tend to travel together. Whether you address this through deliberate stress reduction, through improved sleep, through physical activity, or through some other approach is a personal question, but dismissing it as irrelevant to your eye health is a mistake. For direct liver support, milk thistle has among the strongest evidence bases of any botanical agent in hepatology, the medical field focused on the liver. The active compound is silymarin, and it is available in multiple forms. Ground seeds that can be added to food, oil, and standardized pharmaceutical preparations. The drug formulations, including preparations standardized to defined silymarin concentrations, work through a clear, well-characterized biochemical mechanism. Silymarin stabilizes the phospholipid bilayer of hepatocyte cell membranes, making them more resistant to toxic injury. It stimulates protein synthesis in hepatocytes, accelerating cellular regeneration after damage. And it functions as a potent antioxidant, scavenging the reactive oxygen species generated when the liver processes toxic compounds. This is not folk medicine. These mechanisms are pharmacologically documented, and silymarin-based preparations have an established evidence base in liver disease management. If you are serious about supporting the metabolic environment in which your eyes function, the liver is a legitimate target, and milk thistle is a legitimate, evidence-supported tool. Here is your complete, clinically organized protocol. 3 exercises, a combined investment of 3 to 5 minutes per day. The wipers, full amplitude horizontal sweeps along the outer edge of your visual field, targeting the extraocular muscles, releasing chronic tension, and restoring blood flow to the retina through reduction of mechanical compression on the globe. Vibrational massage, gentle, bony-supported fingertip vibration on closed eyelids for 20 to 40 seconds, targeting deep orbital tissue, choroidal circulation, and overall ocular fluid dynamics. Circular accommodation training, multiplanar, distance-varying ciliary muscle loading using your finger as a near visual target, producing a substantially more effective training stimulus than standard linear near-far exercises. Attach each exercise to an existing daily anchor. Commit to it the same way you commit to brushing your teeth, not because it feels urgent today, but because the compounding benefit over months and years is what produces the outcome you actually want. Alongside the exercises, reduce fried, smoked, and heavily processed food from your regular diet. Consider a course of silymarin-based liver support. Test your vitamin D level and correct a deficiency if one exists. And take an honest look at whether chronic stress or sustained emotional strain is contributing to the systemic inflammatory burden your body and your liver is carrying. This is what evidence-based medicine actually looks like when it's practiced for the benefit of the patient rather than the revenue model of the system. You are not helpless in front of your own biology. Your eyes are trainable, your supporting physiology is improvable, and the information to do it is available to you right now at no cost without a waiting room. The healthcare system was not designed to give you what I just gave you. Prevention does not generate billing codes. Self-care does not generate repeat visits. I'm Sam Waterling, and I built this channel because 15 years of clinical practice taught me that the gap between what patients are told and what they could actually do for themselves is enormous. And that gap exists because closing it is not profitable for anyone except the patient. Subscribe to Dr. Waterling, leave a like, and help this channel reach 1,000 subscribers. That number unlocks the ability to reach more people who deserve straight answers. Help me get there.